Chapter 16, Impaired Posture. Posture will incorporate both static and dynamic components. Static, by definition, is the alignment of body segments to maintain a selected position in space. Dynamic is the ability to appropriately control and maintain a well-aligned upright posture while moving the body in space. Optimal alignment is just like what it sounds. This is the ideal alignment in which positioning is centered and relaxed for all joints of the body. And that's the important thing I want you to remember is the position is centered and it's relaxed for all joints of the body. So if we start to see tension on one side of a joint versus another, then that's probably not optimal for the patient. APTA's Guide to PT Practice, the alignment and positioning of the body in relation to gravity, center of mass, and base of support. The American Academy of Orthopedic Surgeons defines any deviations from optimal posture as the faulty relationship of the various parts of the body which produces increased strain on the supporting structures and in which there is less efficient balance of the body over its base of support. So we have to think about this specifically with habitual postures. How many of you guys, as you're listening to this recording right now, are slumped or are cocked off to one side or sitting with your head poking forward in kind of a chin poke position? What is our habitual posture? Specifically, those that happen in static postures are going to be the ones that we're probably going to hear about the most, because those are the postures that we tend to sustain most of the time throughout the day. So if you have your typical desk worker or somebody that sits in their favorite chair at night to watch TV, any of those kind of things are their habitual postures, and we need to make sure and ask specific questions when it comes to this. The other thing that I've noticed a lot the last few years is the increased use of cell phones and tablets, and therefore our patients in their habitual posture at night when they're going through Facebook or looking at news or reading a book on their cell phone or their iPad tend to get in much more faulty postures than what they did previously. So making sure that we're asking the right questions and knowing how to educate our patients is really important. Common postural problems. Now the skeleton on the left shows more of an ideal posture, and you're looking at kind of the plumb line as it goes through the body and what that looks like all the way through from the skull all the way down to the feet. And then looking at postural issues, so sway back, where's the plumb line land, forward and back of the head, that sort of thing. Does the pelvis move forward? Does it move back of that kind of center line? Military back. Again, these are all positions where if you look at them, something's going to be tighter or less tight on different sides of the body based on their habitual patterns that they get into. And so making sure that we know that, because although this might look and feel normal for them, it's not really normal. The body's having to balance out in a different way. Some muscles are having to work harder than others. So think back to our definition of where everything is working in unison with one another on the front and back side of each joint to have better symmetry there. We've got obviously the flat back. So if our spine is flat when it's meant to be in that curved spine, like the ideal posture shows, something else is going to give when it comes to that. Kyphotic, lordotic postures. So again, if we have increased movement in one area, something else has to counterbalance in another area, because our body has to be working against gravity, and so therefore we have to make up the difference one way or the other. And then the forward head posture at the very end. And I'm starting to see a whole lot more forward head postures than I did when I started clinical practice. And I think so much of this is from increased cell phone use, and tablet use than what it ever was before. Here's another one that I see a whole lot of, specifically with, I think, the advent of increased cell use, is the forward head posture. So we've got the tight suboccipitals, we've got weak cervical flexors. Your head is definitely going to be in front of that gravity line. So for this patient, they may complain of neck pain. They may also complain of thoracic pain. So you have to know where their complaints of pain are, but then also look through the whole body and make sure that we're assessing the entire body to see if they might have a give somewhere else. Because we're always going to compensate. It's what our body does best whenever we have malalignment issues. Thoracic kyphosis. We definitely see an increase in this after the age of 40, and I tend to think that we're seeing this more and more with younger people too. And again, I think this goes back to kind of our habitual postures of, sitting around more, being less active than we ever were before, especially with our younger kids too. So many of them are, sitting in a desk working on their tablets now, that so many people have to use computers or tablets in school, and they're not getting up and moving around as much as they used to. But speaking of the geriatric population, we definitely see an increase in fall risk and kyphosis. So there's a correlation between increased fall risk and those that have increased kyphosis. And you can think about that making sense if we look at the skeleton here on the far right hand side. When that head is further forward, that changes our center of gravity, and therefore we could tend to want to fall a bit more because of that. So making sure that, again, why are we addressing things? Are we addressing them due to a pain issue, due to a balance issue? It can be both, or one or the other. Hyperkyphosis is commonly observed in those older adults like we just talked about, and specifically in women. I also see this a lot in women that have larger breasts. So maybe from their teenage years on up, maybe they've been a bit embarrassed about their chest size, and therefore they'll tend to go into a bit more kyphotic posture to hide that. Or maybe it is just because of the weight of the chest, and maybe we need to talk about, better bras, better support to support them so that they don't get into those kyphotic postures. Clinical association has also been seen between kyphosis, osteoporosis, and then increase in vertebral fractures as well. Low back pain. We all know, and the research has shown, that numerous people are treated with low back pain every year in our emergency rooms and at the doctor's offices. And this is probably the primary thing that we see in our clinic, is patients come in complaining of low back pain. Studies show that a majority of Americans will be treated for low back pain at some point in their life, whether it's with medication, whether it's with physical therapy, all kinds of different things. But making sure that we're looking at the whole body, again, could just be the low back that they're complaining of, but making sure that we know that. A loss of the lumbar curve is an independent predictor of vertebral fractures. And if we start to lose that lumbar curve, where are we making up the mobility? Is it in the thoracic spine? Do we go into more kyphosis? Do we go into that forward head to make up for that loss of the lumbar curve? So again, we have to look at the entire spine to see what's going on there. With these patients, with low back pain, there have been studies, and I believe it was United Healthcare just a couple years ago, that looked at the incidence of patients that complain of low back pain and are seen with low back pain in a physician's office. And the numbers at that point, about 2 years ago, were that about 10% of those patients were actually seen in physical therapy. So there is a huge number of people that aren't being seen by PT that would really benefit from the services that we provide. So again, I think education is so key and so important when we're working with our current patients, but then also letting them know, we can treat family and friends that might have the same kind of condition as well. So making sure that we share that information. There are definitely age-related changes that happen, and a lot of these changes start to happen around middle age. So around age 45, we start to see height changes in both men and women. Women definitely have an increased loss in height compared to men. The decrease per women in their height is about 0.1% per year in women after the age of 45, and men is about 0.02. So significant difference between the two, which can equate to up to almost 2 inches over a lifetime. And you'll start to see some of your older patients talk about how they used to be so much taller. Some of that's definitely going to occur due to the intervertebral discs flattening out a bit. So we'll see some of those structural changes in the bones and the joints, but can also be a postural issue as well. So can some of those be changed with some postural training and postural exercises? And I definitely think that they can. And if nothing else, we're decreasing the stress on the body by changing the mechanics in the body and how the muscles interact on both the front and the back sides of the body. Over 90% of older adults demonstrate some level of disc degeneration, regardless of presence of clinical signs and symptoms. I believe this is talked about a whole lot more now in school than it ever used to be, but so many of our patients come into us and they're complaining of back pain and they really want to get an MRI or an X-ray to show them exactly what's wrong, I really stress with my patients that it's fine to be able to get that kind of imaging, and sometimes it's really helpful based on the symptoms that they're presenting with, but it doesn't usually change how I'm going to treat the patient because I'm treating them based on my objective findings, and so that doesn't really matter. But so many people kind of live and die by what the MRI shows, and that can be very stressful for them. So if it does show disc bulges at different levels, they might get very stressed thinking they can't move or shouldn't move because it could be very traumatic or damaging to their body. And I think sometimes as healthcare professionals, not so much in the PT profession, but I do hear about it still happening in the PT profession, but sometimes other healthcare professionals will tell patients, yeah, you've got a really bad back, you've got a lot of discs that might be blown out or might be bulging, and this can cause a lot of bad things to happen to your body in the future. So letting the patients know that it's healthy and it's needed for them to keep moving and stay active. Discussion of muscle and soft tissue changes as we see in aging. With aging, we see a decrease in the water, elastin, and proteoglycan content in our bodies. And with increased age, this leads to more possibilities of getting injured. We also see increase in the cross-links between adjacent tropocollagen molecules that contribute to increased stiffness and decreased maximal length. So when our patients start to tell us that they're a whole lot stiffer than they ever used to be as a younger adult or younger person, there are some specific molecular changes that do happen to cause this. And abnormal muscle elongation leads to increased number of sarcomeres and ability to develop maximum tension only in the more lengthened position. And this last one is definitely true of all of us. So again, think about that forward head kyphotic posture because we're sitting in class all day long or studying all night or watching TV or glancing at our cell phone all day long. We're going to get increased lengthened muscles on one side of our body and shortening on the other side. So again, that's not normal posture, and we're getting into some of those faulty posture habits. So there's some comic chronic conditions with the musculoskeletal system that we see associated with postural alignments as we get older. Not surprising, think about osteoporosis, spinal OA, and spinal stenosis. The role of posture in some of these spinal conditions, osteoporosis, is defined as a systematic skeletal disease characterized by a low bone mass and a microarchitectural deterioration of bone tissue with a consequent increase in bone fragility and susceptibility to fracture. The estimates show that about 50% of women and 20% of men who reach 50 years of age will have a fragility fracture in their remaining lifetime. Most common in the spine, we'll see an anterior vertebral body fracture, which may or may not be diagnosed. So we have to make sure that we're asking the right questions when we're assessing our patients to see what brought them in for therapy and what movement might be associated with their pain. So what's the most common position for these fractures for osteoporosis? So if you said flexion of the spine, you would be correct, specifically thoracic spine, because that's where we tend to see a lot of those vertebral body fractures happen, is with increased flexion. So doing loaded flexion activities is not always ideal for our patients if they have osteoporosis that isn't well managed. The next common spinal conditions, spinal OA, that's increased with our advancing age. We see that in all joints, but specifically the spine. And then we tend to see a lot of vertebral wedge deformity, very common in those with spinal OA. And that can lead to pain, neural sensitivity, neural symptoms, and dysfunction. And so again, we need to fully assess our patient and see what the best treatment strategies are for them moving forward. And then spinal stenosis is another spinal condition that we see in our geriatric population. There's numerous reasons why spinal stenosis occurs, but some of those might be hypertrophy of the spinal ligaments, OA, or disc generation. And I also think that this can happen due to kind of the hypertrophy of spinal ligaments if our bodies are in poor posture for a long amount of our time throughout our life due to habitual postures. That can put increased stress on the spine. And then I want you to think about what the clinical presentation with a patient with spinal stenosis might be. What would they typically complain of? And I assume with this one, they're going to tell you that they have most pain in the spinal extension movements or even just in upright walking. So talking about, unloading the spine using a shopping cart or a walker decreases their pain significantly, or if they tend to like to lean over on countertops to unload their spine, we might be looking at somebody that has spinal stenosis. So again, making sure what activities or what movements precipitate their pain or decrease their pain can help us kind of nail down what might be going on with those patients. So PT management, taking a proper history. We've already talked about this numerous times throughout the semester, but medications can definitely play a role in this. If they're taking medication that kind of demotivates them or depresses them, they might have decreased motivation to stay active and stay healthy. Medications can also cause some postural instability, so maybe patients get dizziness with some of their medications, and we need to make sure and take that into consideration. If that is the case, we need to make sure that the patients are talking to their doctor or their pharmacist to ensure they know and can find a better way for them to be safe with their medications, or maybe adjust or change the medication they're taking. Medications can also lead to fatigue and weakness, and again, that can cause falls. Or if you're fatigued or weak, you might go into those poor postural habits because of that. Medications, like we just talked about, can cause depression. They can also cause postural hypotension. With our objective testing, just like we do with all of our patients, we want to assess pain, what's causing the pain, how can we decrease the pain or mitigate the pain, and then looking at the full body alignment is important as well. When looking at alignment, we want to know what we're looking for. And I know when you first start practicing, it's hard to know everything to look for, but just think in general, what are we going to be looking at when it comes to the body? Do you see something obviously, glaringly wrong when it comes to our patients, when it comes to posture? And it's good to look at them from all angles of the body to see if we see any variances from right to left, front to back. You can use plumb line like they do here in this example, or even just having them line up and look at different landmarks of the body. Making sure that you're also not just looking at the painful sites, but looking at the full body to see if something else might be going on. Just because a patient's complaining of pain doesn't mean that's the pain generating area of the body. So there's all kinds of ways to assess the alignment of the body. We want to, like we just said, look at the total body alignment. We want to look at the spinal curve alignment, and there's all kinds of different things that you can use. There's a flexible curve ruler, and I don't know how many of you all have seen those, but they're anywhere from 2 to 3 feet in length. They're this rubbery material that have like a metal insert in the inside of it and allows you to put it maybe right up against the spine to see specific angles. So you can show the patient, like, here's your thoracic curve that we're seeing, this is what it looks like, and that way they can kind of get a visual of it as well. That's helpful just to kind of help the patient see, but you can also use that to take measurements if you need to. So taking that, transferring it then to a flat surface, and then you can take measurements off of that. Using an inclinometer is another way to assess the spinal curve alignment. Looking at the head alignment, is it, again, tipped forward, back, right, left, rotated right or left? So making sure that you're looking at all that. And then extremity alignment. So looking at the shoulders, do they demonstrate like a handedness pattern? What about their hips, knees, and feet? Do they tend to turn in with one leg or turn out with one leg? And where is that turnout coming from? Is it coming from the tibia, or is it coming from the femur? Is it coming from the pelvis? So making sure that you're noting where you're seeing these malalignments, so you can assess if it gets better, worse, or stays the same as treatments go on. On this page, we can see how using the spinal curve or that flexible ruler like we talked about earlier is shown in that top left-hand corner. That therapist is putting that flexible ruler up against the patient's spine and then pulling it back, and then you can see what the angles look like. So then from there they put it down and then kind of traced out like what the angles look like, what the alignment looks like. I don't typically get into these kind of specifics when it comes to working with my patients, but I'm just sort of noting how far off of midline they are so I can assess that. That would be a good way to assess it if you have a patient that's one of the goals that you have set for them, to see if you can improve or change some of these spinal faulty postures, or to see whether or not it's fixed. So are there ways that we can make improvements in it, or is it a fixed posture now that they've had it for this long? And then looking at the one on the right kind of talks about looking at the differences and what the terms are called, looking at the thoracic and the lumbar spine and the curves associated with those. Now I want you to think about how you've tested the range of motion for the spine in your clinic or in past clinicals that you've done. What have you used and what have you seen? So have you used the inclinometers? Have you used a ruler? There's all kinds of different ways that you can do it, but making sure that when you're doing that, you note how you've done it so you can assess it and reassess it again later, or that somebody else can do that following you. So this is one of our patients that we've had in the past. I don't know if you can see that, but he had lumbar surgery sometime prior to coming in to see us, and seeing where that pain is there. Where do you think, where would you assume that this patient is going to have pain? Would it be in the neck? Would it be in the thoracic spine, the lumbar spine, shoulders? For this patient, he denies having any back pain at all. When you ask him about pain in his back, he has none. Now, more than likely, he probably does have some low level that he's just gotten used to dealing with for a long time, but that's not where he reports any pain. What he reports is hip and leg pain on that right side. That's where he reports the pain. So again, just going after the hip and knee might make you miss some of the other pieces. Obviously, he's got some postural, faulty postures here when we look at him in standing, and so hopefully most people would pick that up. But again, making sure that we're looking at the full body. And we've got his shirt pulled up here so you can start to see the significant changes when it comes to his posture. But if you have his shirt down, you might miss some of that stuff. So make sure that you're palpating the patient, and if you feel comfortable and the patient feels comfortable, pull that shirt up so that you can see what their spine looks like. Most patients don't have a problem with that. Again, they're there to help. They're there to work with you to get better, so they're willing to do whatever it takes to get to the bottom of what's going on with them and help get them feeling much better. So we've already talked about the evaluation when it comes to our patients with abnormal postural complaints or pain. You've come up with your diagnosis, figured out what you want to do, come up with a prognosis based on what you've seen and even your previous work with clients and patients, and then you just set forth a plan of care. So thinking about what sort of interventions you want to do. Do you want to do kind of some therapeutic exercise to correct some of their faults, maybe some specific core strengthening exercises, extremity postural exercises that can also work the core as well, static stretches or dynamic stretches through ranges of motion for the trunk and extremities, and then overall conditioning and endurance exercise for these patients as well. We definitely want to make sure that we're targeting interventions to improve their ADLs, especially if they have some specific ADLs that are troubling or problematic for them, making sure that we're addressing those, giving them any sort of instructional resources that we can. And we use a system at our clinic called In Hand Health, which is a home exercise program that allows us to also add any resources into the patient's system, and the patients then access those exercises and those resources via an app that they can use on their tablet or their phones, that might walk them through the exercises, that talk a little bit more specifically about any diagnoses that we're seeing with them that we want to educate them further on. Are there any manual therapy contraindications that we have? We need to make sure that we're aware of those as well. Maybe there's some patients that we need to be a bit more hands-off with based on what we've seen with them, or certain areas of the body that we need to be mindful of when we're working on it. Are we going to do a ton of overpressure and rib screws and thoracic manipulations on somebody that's got a fixed thoracic kyphosis. Maybe, maybe not, but you need to make sure that you know what the contraindications are for the patient in front of you. And then do we need to use external supports to kind of support and stabilize the patient from there? There's all kind of treatment options that we have. Spinal mobilization, like we talked about previously. So postmenopausal women with osteoporosis received passive angular mobs of the thoracic spine. So there was a research study done on this, and they did see improvements over a 3-month time period. So again, you have to determine whether or not that's a mobilization or a manipulation. But you know, if we're just doing some mobilizations to see if we can improve that mobility of the thoracic spine, that's fantastic. I will say also with therapists that tend to do heavy manual therapy, we will start to see, and especially as they get older, myself included, that I do tend to have a very restricted thoracic spine due to being flexed over my patients and doing different manual treatments with them. So again, finding out the history of the patient and what some of their habitual postures are can help us understand how to undo some of those habitual postures they've gotten into. Other treatment options include muscle energy techniques. So you're using neuromuscular inhibition principles, maybe soft tissue mobilization, contract, relax. You can definitely improve any sort of hip or shoulder mobility with those kind of contract, relax mobilizations. Lumbar supports. It's not really effective, but for some of our patients, if their postural patterns are getting worse over time and we need to support where they at least currently are to not make it worse, sometimes I will recommend lumbar supports, but it depends on what's the best interest of the patient. It's not something I want them to be in all the time, but if it supports them enough to be more functional in their environment, it is important. I've had some patients that I have recommended that they get into lumbar supports, but it's very rare that it's something that I do, at least in my clinic. Taping for postural impairments is another option that we have as well. And in 2018, Greg et al. Found no increase in trunk EMG measurements with taping. So there's some studies that show that it doesn't help all that much, and other studies show that it does some. For me, I use it more as biofeedback for my patients. So I do some taping, but maybe I'll have them use it as a biofeedback mechanism. So if the patients tend to go in a lot of thoracic flexion or lumbar flexed activities that are increasing their symptoms, I'll tape them to support their body and allow them to feel the pull of the tape on their body if they go into those flex postures that tell them, oh, I'm not supposed to do that, I should watch and try to be mindful of that posture. So maybe for those patients that tend to read a lot, whether it's with a book or with a tablet or a phone, and they get into those very flex postures of the thoracic spine, I can put tape across their thoracic spine from superior to inferior, tape them down in a neutral posture, so anytime they go into that flex posture, they start to feel that, and it helps them remember to stay out of those bad postural habits. And then orthotics is another thing. So if we're supporting from the ground up, maybe that helps improve the overall alignment of the body. Feet do tend to get flat, and we lose that arch as we get older. And so therefore, if we support the arch a little bit more, that can help with the control all the way up the body, from the tibial, maybe internal rotation, or even hip internal rotation at the femur. That can support it a little bit more and get them into a better alignment. Thanks for your time today.